And we now move on to the highlight of our webinar, a grand show today, because we have the most illustrious ophthalmologist in the world, may I say that, Dr. Tamara Fountain, who had very kindly and graciously accepted to give the oration on occasion of the 10th anniversary of Asia Pacific Ophthalmic Trauma Society. When I approached her the very first time a few months ago, her immediate response is, yes, let me put something together and let's work together itself. She is a professor of ophthalmology at the Rush University Medical Center in Chicago. Most importantly, from an ocular plastic surgeon, extremely proud to say that it's a fellow ocular plastic surgeon who has an accomplished track record of clinical research, education, publications, and most importantly, leadership. Was a past president of the American Society of Ophthalmic Plastic Reconstructive Surgery, and going on to helm the leadership of the American Academy of Ophthalmology, the society that we all aspire to become members. We became members years ago. We've been looking to for training and education and quality and standard and so on and so forth, that she's achieved the pinnacle. So I'd like to introduce Dr. Tamara. Initially started off as a friendship over the years, but she has been extremely supportive for our education. And this is a picture on the left from our 30th anniversary at NUH in 2016, when she flew all the way and shared her time and expertise. That's when I was really influenced by her personality in addition to her scientific contributions. And of course, last year, the 50th year of the ASOPRIS evening, Dr. David Reifler and Dr. Tamara Fountain. What I admire more about her is not just the present personality. Most of us are physicians and aim to be healers. And most of us start off as simple ophthalmologists. But she then went on to become an accomplished ophthalmic plastic reconstructive surgeon. And now with ophthalmic trauma becoming an important aspect of ophthalmology, which has unfortunately been neglected for decades past, when Ferenc Kuhn really woke us all up to better management, better diagnosis. This physician has transformed herself from an ophthalmologist, a physician, to a physician leader and risen to the highest level. So I give you Professor Tamara Fountain on behalf of Professor Natarajan and Dr. Azad and the entire APORS team. We'd like to present Dr. Tamara Fountain, the oration, the certification, which will be mailed out to her, and the medal on behalf of APORS, and give you Professor Tamara Fountain. Dr. Natarajan, if you'd like to say a few words.
Heartiest congratulations, Tamara, and we are very happy to have you. And a nice, I saw the old picture which you have taken in 15-16, and I'm glad you are here. And on behalf of Asia Pacific Ophthalmic Trauma Society, we are really proud that Asia Pacific Ophthalmic Trauma Society will work with the entire world, with Ferenc Kuhn as president of International Society of Ocular Trauma, with yourself as the president of American Academy of Ophthalmology, when you have 4 more presidents in this group. So I'm happy you're going to speak on trauma, triage, and treatment. And as he said, you're a physician healer and a physician leader. And I'm happy that you're also, I think, from the leadership development program from Academy, where even I come from. So I'm happy that we are going to work together. With this, I think we will mail you we are proud, we already signed it. We have sent you virtually, but I think we'll send it physically also. We wanted to surprise you, but it's early morning in Chicago. We couldn't get a person to come and give you that early morning in this cold weather. And I hope with the warm greetings, you will feel warm and give us the wonderful oration. Thank you.
What a wonderful introduction. I really, truly wish we could all be together. And Ganga, it was about 10, maybe 11 years ago, we were at the MASCAL meeting in Dubai, and we struck up a conversation. We happened to be staying at the same hotel. And that was the beginning of a very rich friendship that's brought, I mean, I see so many people on this call that I know and have met across the continent. So I'm looking forward, like everybody else, to being in person when we can convene and when we can hug. And it's such an honor to be with you this morning. And Ganga asked me to summarize the American experience of ocular trauma. So over the next few minutes, I'm going to try to do that. Why is this important? I think we've heard some excellent speakers over the last couple of hours from all walks of life and all corners of the world. Ocular trauma is a major issue, and it's a major source of ophthalmic impairment. We have thousands of Americans suffering from trauma each year, And more importantly, the outcomes are often quite poor, with almost a third of people having final best corrected vision of less than 2200. When I thought about America and trauma, it made me realize that how you define trauma really is impacted by where you are. And I really was intrigued by Dr. Talma's presentation and how he really so graphically illustrated the differences in the continents, in what kind of trauma we see and how we cover the trauma. It's a reality. I think it's an unfortunate reality because of the ubiquitousness of firearms in the United States, that we probably see our greater share of gunshot wounds and ballistics wounds here. And I'm not sure about other countries, but I can tell you that there is about one domestic pet dog for every 3 Americans. So we love our pets here, and perhaps we have a greater representation of dog bite trauma than we might see in other parts of the world. But as Dr. Jeannie pointed out, there are universal themes when we look at the definition of trauma with domestic disputes, sports issues, work issues. So we have some common themes as well. We've had speakers, and Dr. Jeannie took us through the Italian experience in COVID. We are finding here, again, trauma tends to happen where you are. And with COVID, all of us have been spending more time in our homes. And so it's not surprising that we're seeing more trauma originating out of our households. And as has been mentioned by previous speakers as well, that we are finding that it takes a little bit longer for people to present. People are traveling further distances as well. And they're less likely to have health insurance, we're finding, during these COVID times. We see almost 2 million eye injuries, and about half of these are seen in our emergency departments, and the others are seen primarily in our offices and other less intense facilities. As has been described, we see in our country as well that overwhelmingly the patients are male and young and white in our country. And we see various types of injuries, including superficial injuries like corneal abrasions, but also foreign bodies, blunt trauma, and of course, open globes. When we look at the emergency room experience, we all know that the skills of surgery have been honed on the battlefields for millennia. But we in America have also patterned our trauma system on lessons learned in war. From World War II, when we primarily treated people on the battlefield and did the best we could in the war theater, to lessons learned in Vietnam and Korea, where we started having regional care facilities, and as my dear colleague, Dr. Mazzoli describes, echelons of care where we stabilized and then transported for further care as needed. And we've refined this now to very sophisticated ways of getting our military soldiers out of the war environment and back into the domestic environment for the totality of their care. And we utilized some of those lessons to organize our National Trauma Center system here in America. And this is a really nice article out of the Chinese Journal of Traumatology that I will summarize here for you all. In 1966, the Committees of Shock and Trauma, which were part of the National Academy of Sciences, published a sentinel volume of Accidental Death and Disability, the Neglected Disease of Modern Society. And in this tome, they called for an increased role of the federal government to standardize trauma systems. Out of this advocacy came the National Highway Safety Act of 1966. At the time, motor vehicle accidents were a major source of ophthalmic trauma. And so from this came our initial grants that funded the early trauma system. And here in my native Chicago, Cook County Hospital was the epicenter of the first statewide trauma center in the United States. Later on in the 70s, the American College of Surgeons gave more granular detail to the designation of our trauma centers, from the top level, level 1, where we have the entire management system of trauma from the time the patient hits the door to the end of their visual rehabilitation, and then stepping down accordingly to different intensities of level trauma in our country. And we have found that this trauma-centered system has been working well for us with a decrease in mortality initially, as well as better outcomes over the course of the first year. And we have found that both our morbidity and mortality from general trauma has steadily decreased from the 1960s. However, there are areas that are still challenging us with this system. Despite the initial call for federal standards, we still have not realized this goal. Our access is uneven. We still have 50 million Americans who are greater than 1 hour from even a level 1 or level 2 center, yet we have 40 million Americans who are with less than an hour from more than 20. So we have uneven access. If you live in the Northeast, areas like Boston, New York, you're in good shape. If you live in some of our more rural areas, in the West, particularly Utah and Wyoming, you are not as close. It's also expensive. We are obligated to treat all emergency injuries regardless of the ability to pay. With the corporatization of medicine, for-profit hospitals are getting out of the business of staffing trauma, which further adds to the burden of our academic centers as well. Within our trauma center, we still have not been able to establish a designated ocular arm. The going motto for trauma care is save life, sight, and limb. But in reality, in most cases, the emphasis really comes down to life and limb, and sight is secondary. We also are seeing in the United States a crisis in the willingness of American ophthalmologists to provide ER and inpatient call coverage. The Academy established a work group 2 years ago to address the reality that fewer of our members were willing to provide hospital coverage. This increases the burden on our academic medical centers, and it doesn't do very much for our reputation as ophthalmologists within the broader house of medicine. What are some of the reasons? We looked at and detailed with our surveys here. We have less of a need for hospital privileges, so therefore our ophthalmologists are not tied as much to the hospitals. And in many cases, the requirement of providing hospital call comes along with your hospital privileges. So as ophthalmologists have migrated away from hospitals, they no longer provide that call. There are economic pressures, both in the fact that the trauma call is very poorly reimbursed in most cases, but also there are opportunity costs when you're providing care in the ER, you're not in your office, you're not in the operating room taking care of your own patients. And these cases, as we all know, are ripe for litigation. You know, we don't sometimes have a good history. There are steps that are made in the heat of the moment that may come back to affect us as well. And, you know, trauma call is usually after hours. As we've talked about, this has ramifications for how you feel the next day and contributes to burnout issues as well. I was intrigued by Dr. Talma's talk, speaking of, and I know this as well, that, you know, with the increasing trend towards subspecialization, it's very difficult to find ophthalmologists who are capable and comfortable providing care for anterior segment, posterior segment, and orbital trauma all at once. So I think, you know, we could use more of these South African residents in our country to help take care of all this trauma at one time. But the reality is that emergencies happen all day, every day of the year. And we find that 20% of sentinel events in our emergency departments are related to the absence of specialty coverage. And the reality is, if our community ophthalmologists aren't available, there are other eye care providers who will probably be quite willing to step up and take that call. So the work group recommendations were that member education on most ER and inpatient conditions is paramount. We don't see the volume in the United States that our colleagues across the world do, as has been described by Dr. Legault as well. We really need to focus on that. We also came up with some policy strategies to reduce the call burden. We find that about half of ER ophthalmic visits are really not true ocular emergencies. Is there a way we can triage these in a better way, make offices more available to take walk-in patients to decrease the burden on our emergency rooms. In addition, we have a hospitalist model here where internists no longer follow their patients into the hospital setting. They transfer their care to dedicated hospitalists. And there seems to be some interest in exploring an eye model of that same thing, where we have dedicated ophthalmologists who only take care of patients in hospital settings. And in addition, as Dr. Legault described, our military ophthalmologists are probably one of our greatest assets. And so I think we need to increasingly leverage their capabilities and their willingness to take care of our civilian population. I think that's a win-win for everybody. Speaking of our military ophthalmologists, I think that the levels and the echelons of care really come into play when we see mass casualties and polytrauma, as for instance, like we had in our Las Vegas shooting a couple of years ago, as well as Boston Marathon. And I think these are situations that most mimic the kinds of decisions that have to be made in the battlefield. And I think that we are better served by a synergy with our military ophthalmologists, and many of the tools that we use in our mass casualty situations are derived immediately from our military ophthalmologists. So physician education, we spend a lot of time at the Academy. This is really, if you want to think about it and cone it down, this is our primary mission. It's what the Academy does. And we focus on making sure our members are good diagnosticians, that they know how to treat, and that we don't forget the role of rehabilitation. Intraocular foreign body is one of the top 3 missed diagnoses for ophthalmologists in the United States. And so trauma is up there for one of the things that we tend to miss in many cases. We have lots of educational offerings, and I will emphasize that the vast majority of our trauma content on the American Academy's website is open access. You do not have to be a member. About the only thing that you cannot access is a couple of courses and the access to the wills manual, because we pay for these things and we cannot make those available to everybody. That's a member benefit. But just about everything else is open to anybody across the world. We have collaborated with the American Society of Ophthalmic Plastic and Reconstructive Surgery to make a separate center for orbital trauma. Open globe, as we have mentioned before, we don't see quite as much of these types of traumas in the United States as some of our colleagues across the world, but they are probably one of the most common emergent situations that we encounter. So we have many videos on the website that will take people who don't see these types of traumas very often and give them some guidelines for this situation. And again, we also focus on rehabilitation. We sometimes forget that aspect of our trauma. We also educate our patient and public population through our iSmart arm. And so when we talk about protecting sight and empowering lives, this is what we mean by protection. And so when do you wear eye protection? Well, you wear eye protection when you're doing dangerous things, no matter where that is, whether it's at work or whether it's at home. And we have all of this information on our iSmart website to help our patients recognize the hidden dangers in their everyday lives. Our recreational activities, there's an old saying, it's all fun and games until somebody loses an eye. And that's actually literal in our case. There are a lot of recreational activities that we pursue that we think of as relatively innocuous, but they're not. And we try to raise the level of public awareness on this as well. Every January 1st and every July 4th, we have a campaign on the hazards of homemade fireworks, as well as the hazards of a cork coming out of a bottle. We showed videos on how to properly remove a cork from a bottle, and again, increase public awareness as well. Sports are another source of trauma. Interestingly, basketball, it's always a great trivia question if you want to ask somebody in the United States, which sport is the most dangerous to the eye? And people don't think about basketball. And it's obviously not from the basketball itself, it's from the activity under the basket, or what we call in the paint, with lots of elbows and lots of fingers. And we know that people get blowout fractures and ruptured globes, and certainly corneal abrasions. We saw, unfortunately, in our country last year as well, ophthalmic trauma come to public awareness because of the use of rubber bullets by law enforcement for crowd control. And we had over 30 ruptured globe injuries from rubber bullets within the first week after the death of George Floyd and the protests that arose from that incident. So we immediately published online information for people who were protesting how to protect their eyes, and also to call on law enforcement to consider other methods of crowd control rather than the non-lethal rubber bullets. This article just came out, excuse me, about a week and a half ago, looking at the United States Eye Injury Registry, both past and future. And we see here some very familiar authors, as been described, very energetic members of our ASOT organization. And the original trauma registry was established by ASOT back in the late 80s. And a lot of great things came out during this time from this. We came up with our Birmingham Ocular Trauma Score, the General Ocular Trauma Score. We looked at epidemiology and determined trends in injuries and the nature of injuries and who was getting those injuries. And we use this information as the basis for a number of policy recommendations. However, the organization went inactive in 2013, and we didn't have the benefit of this type of registry. And while there were many other types of databases, these primarily did not address the ophthalmic arm of trauma. And more importantly, even the Academy's IRIS registry, which I believe is one of the largest clinical registries now in the world, because our academic centers for proprietary EHR reasons have been traditionally locked out of the IRIS registry, we've lost, or we don't have traditionally access to that type of information. And so even the IRIS registry suffers from a lack of ophthalmic trauma related to our academic medical centers. And we still have a lot of questions that we'd like to answer as it relates to ophthalmic trauma. Dr. Ocampo mentioned the difficulty in funding, and you know, we see a little bit of that here in the United States as well. We all have these kinds of questions that we want to have answers to. And so the American Academy of Ophthalmology is helping and partnering to give as many resources to a resurrected ASOT as we can, so that we can resurrect this registry, because I think that ASOT is probably in the best position to do this kind of work going forward. So we're going to try to give them as much help as they possibly need. And so we know, I'm really excited, and it was a real pleasure to hear Dr. Legault earlier today, because I know what great hands we are in. So I'm very excited about the renaissance of ASOT and working with them going forward. So our take-home messages for the US approach to trauma is that, of course, ocular trauma is a public health issue. And though we have a robust tiered trauma system in the United States, we still have challenges with coordination and funding, and remaining vigilant to make sure that the ophthalmic arm is represented both at the policy level as well as the clinical level. We have work to do with our own members to encourage ophthalmologists to maintain their ties to their hospital ERs and inpatients. And we need to continue to work with our government and our professional societies to establish some national standards. We continue to increase an emphasis on our education. Again, we tend to see a lot of trauma as residents, but depending on our practice situations, we don't tend to see as much, depending on where we are and our practices once we get into practice. So we have to make sure we maintain those skills. And don't forget about protection. We hope that we put ourselves out of business one day for ocular trauma. We know that's not a reality, but the more that we can emphasize the role of protection, the better off we'll all be, and we'll fulfill our professional mission. And I really love the emphasis that I've heard from all the speakers today on some of the silver linings of COVID. It has further flattened our world and allowed us to collaborate even more easily as we are doing today. And that said, however, I cannot wait until we can gather again and we can all see and give each other a hug. I want to give thanks to Dr. Rob Mazzoli, who helped frame my thought processes on this talk and give the military perspective. And I also want to acknowledge the thoughts of David Park, the AAO CEO, who helped, and Dale Fajardo, our education vice president, for helping also to educate me on the Academy's perspective on ophthalmic trauma. And again, to the organizers of this course, so many thanks to you for inviting me to be part of this course today. It was the best way of starting my weekend here in Chicago. So thank you very, 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 very much.
Yes, thank you. Yes. Sir, wonderful, Tamara. Heartiest congratulations. I think I keenly watched whatever you presented, and I think I'm happy you are making really a global picture and associating with every trauma society, and specifically highlighted what American Academy is doing. I'm also closely watching, and I'm working with Ravi Goyal sometimes, and he mentioned during the rubber bullet injuries, and they quoted the New York Times, which was there when we had a problem in Kashmir. So I did a lot of pellet-ocular injuries there. So I'm actually following Ferenc Kuhn's idea of primary wound repair immediately, as you said, 24/7. And our hospital per se, and few hospitals in India are doing 24/7. And I think also we want to do the secondary intervention in 6 to 7 days as a second window, and not even wait 2 weeks. And that's what I'm happy to continue what Ferenc Kuhn says. And I think the reason is, I think if you wait too long, we have a problem of repairing the retina. And if you do too early, it's a problem. I think 6 to 7 days is good. So I recommend. In India, we have a problem because of the sometimes violence happens even in the clinics. If they expect some vision, and they all come with no PL and they want dramatic vision. So I think we have written several articles in the press saying that following injury, if you have no perception of light, we can operate, but please don't expect miracle, even though a lot of patients can improve. I think you highlighted all angles, including teaching, and also the various articles in the wiki, also what you mentioned, and then iWiki, as well as in the American Academy. I think it's great. Now probably Kendrick and Rupesh will lead the discussion with the panelists. And there are several panelists from all over the world and all the continents we have here. Again, once again, thank you for honoring us by giving this oration on behalf of the Asia Pacific Ophthalmic Trauma Society. Thank you.